Thank you. It's a pleasure to be here today in Riyadh to speak with you about state-of-the-art asthma treatment. And I have no conflicts of interest to disclose. It is estimated that the lifetime prevalence of asthma in children in Saudi Arabia is anywhere from 8 to 25%. And so therefore, it is a common and chronic illness that is dealt with in pediatric emergency medicine. And I know in my own practice in the United States, it is quite relevant since who have acute asthma care in the emergency department. And so so as the slides are coming up, I can share with you the objectives of my lecture are to define currently recommended asthma treatment for children with an acute exacerbation, to describe the potential benefits of non-standard treatment for emergent asthma, and then to identify areas of where emergency care for pediatric asthma can be improved. And so as the slides are coming up, I want to share a case with you. So let's consider this case of this boy. He is 7 years old, and he comes to you by ambulance. He has a history of eczema and mild persistent asthma. He's had frequent cough, congestion, and fever for the past few days. And today he began having difficulty breathing, characterized by shortness of breath, chest tightness, and wheezing when breathing. And the parents noticed that he was drowsy and tachypnic, with significant indrawing of the chest or retractions. And he was given one short-acting beta agonist treatment before arrival of EMS. And then en route to the hospital, they continued giving short-acting beta agonist. And so he has the classic signs and symptoms of asthma in children: chest tightness, shortness of breath, frequent coughing, wheezing when breathing. And in our setting, the emergency department, pulmonary function testing is not something that is typically feasible to do. And so, typically we rely on these common signs and symptoms to determine and to differentiate, is this asthma or is this something else? And so typically, if we see these common signs and symptoms in a child who's 2 years or older, then we consider that to be an asthma exacerbation as opposed to something else. And in addition, though, sometimes we're seeing these children for the first time that this has happened to them. And so sometimes we have to try a trial of a short-acting beta agonist to see if they're responsive to treatment, to determine if that is the diagnosis. So in the emergency department, other things that we can use to determine the diagnosis, however, are other things. So are there comorbidities? So history of atopy, such as eczema or and seasonal allergies. Is there a past medical history of having frequent wheezing associated respiratory illnesses in infancy and early childhood prior to diagnosis? I frequently will diagnose asthma for the first time. A parent will say to me, oh, I've used albuterol. My child's had difficulty breathing multiple times in the past. And they'll say, but nobody's ever diagnosed him with asthma. And so I say, well, I'm diagnosing your child with asthma today. And so I think that happens sometimes, is that people have their child taken care of, but no one's labeled them with the diagnosis of asthma, even though they have the classic signs and symptoms. I think other things that are important to consider are family history. So we know that having a significant history of atopy in the family, eczema, seasonal allergies, and asthma go together and are hereditary. And then responsiveness, as I mentioned, to short-acting beta agonists. However, chest x-rays are not something that are necessary in the diagnosis. And so when I'm managing a child that has an asthma exacerbation in the emergency department, typically the only times I'll get a chest x-ray are when I'm suspecting that something else may be going on. So for example, if I think that there might be a concurrent pneumonia happening because they're not responsive to treatment, they have a fever, they have asymmetric breath sounds, or perhaps they're having a complication related to their asthma, such as a pneumothorax. Or in other situations, again, if they're not responsive to the maximum treatment that we can give them, they're still not improving, not showing any signs of improvement, perhaps something else is going on, such as pneumonia or heart failure, or if there's other uncertainty about the diagnosis. So I think it's important before we talk about treatment to understand pathophysiology. And so to give a brief recap of the pathophysiology of asthma, allergens and respiratory viruses are the typical triggers for an acute asthma exacerbation. And so when either or both of these things occur, that causes airway edema, it causes mucus and cellular debris to be released into the airway lumen, and also to have bronchospasm. And so this combination of edema, debris, and bronchospasm leads to airway obstruction. And so these pathophysiologic changes are generally reversible, however, with the treatments that we have available to us. And so that's what I'm going to talk about first with respect to what are all the treatments that we have available to us to treat asthma. And so to do this and to talk about it from the state-of-the-art perspective, I think it's important to look at what's currently defined in guidelines. I did find this article by Al Moammari on the Saudi Initiative for Asthma, or SINA. It praises the evidence and makes recommendations for both children and adults in the management of asthma. And so I've reviewed these guidelines, and I will comment on them with respect to what I typically do in my practice in the United States. Also, I think when assessing a child with asthma, it is helpful to use an objective, validated scoring tool to help guide management and to help communicate to other healthcare professionals about the severity of the exacerbation that you're treating. And so the Pediatric Respiratory Assessment Measure, or the PRAM score, is one tool that can help determine acute asthma severity in children. So it's been validated in children 2 to 17 years old, and it is based on a 12-point scoring scale that incorporates suprasternal retractions, scalene retractions, air entry, wheezing, and oxygen saturation, as you can see here. What we know from the validation of the score is that if you have a low score of 1 to 3, that your risk of hospital admission is less than 10%. If you have a score of 4 to 7, that risk goes up to 10 to 50%. And if you have a much higher score of 8 to 12 on the extreme end, that your risk of hospitalization is greater than 50% in the setting of an acute asthma exacerbation. So reviewing the published guidelines, all of these medications are listed. And so rather than go through the treatment algorithm based on the PRAM score, what I'm going to do is discuss each of these medications with respect to the severity of the asthma exacerbation itself, and then talk about some nuances in management with respect to them. So starting first with mild to moderate asthma exacerbations, I think the mainstay of treatment is the use of a short-acting beta agonist like albuterol or salbutamol, using ipratropium bromide, and using some sort of systemic steroid. So when it comes to albuterol, although the use of a meter-dose inhaler and a nebulizer, they're equally effective, from a practical point of view in the emergency department, I find that it's helpful to place the child on a nebulizer because you can mix in the ipratropium with it, and it's easy for our respiratory therapist or our nurse to then step away from the patient instead of having to assist them with the meter dose inhaler with a spacer and having to use 2 different inhalers to administer the treatment. And so from a practical point of view, for the emergent management, we typically in our practice use a nebulizer because it's easy to then step away, see other patients, and then come back and see responsiveness to treatment. And typically, even in the young child, we will start on with a dose of 5 milligrams for the albuterol and for ipratropium 0.5 milligrams. And we'll do this back to back every 10 to 15 minutes, up to 3 times. Most of the patients that we see in our practice, because the more minor patients get triaged to our on-site urgent care, when we see a child with acute asthma exacerbation, it's usually at least at moderate level, if not severe. And so in addition, I think it's important to also consider the use of systemic steroids. Now, although steroids don't take an immediate effect, there is good evidence that the early administration of steroids is impactful on decreasing risk of hospitalization and shortening time for treatment. especially when it's given at emergency department triage. And so that is our practice. When a child presents to the emergency department with an asthma exacerbation, they're given the dexamethasone upon arrival. We had previously used prednisolone, which is a 5-day course, and between prednisolone, prednisone, or dexamethasone, they're equally efficacious. But because dexamethasone can be administered over 2 days, our practice is to administer that first dose at triage, and then if the patient ends up getting discharged, we will discharge them with that second dose so that they don't have to go to a pharmacy to even fill it. And that helps to enhance compliance, because we know that many of our patients, when we prescribe them something, they often fail to fill that prescription for various reasons at a pharmacy. And so having the ability to dispense the medication upon discharge has been helpful to enhance compliance and prevent emergency department recidivism. So for that reason, we did switch to dexamethasone. And a little bit later, I'll talk about the use of dexamethasone even in the pre-hospital setting. So when it comes to moderate to severe asthma exacerbations, if a patient has required 3 breathing treatments of albuterol mixed with ipratropium, then if there are ongoing signs of bronchoconstriction, then the next step for us would be to give continuous albuterol and to use IV magnesium. Now, in terms of the amount of IV magnesium, there are different studies that range from 25 to 75 milligrams per kilogram. Typically, most studies quote a dose of 40 to 50 milligrams per kilogram given intravenously over 20 minutes. One downside of this is because magnesium can relax the smooth muscle, is that you can get hypotension. And as well with the continuous use of albuterol as a beta-2 agonist, it relaxes the smooth muscle. And so you run the risk of hypotension with both treatments and having a widening pulse pressure. So it is important at this point, if you are giving continuous albuterol, giving magnesium, to give IV fluid boluses and or start the patient on at least maintenance fluid to prevent hypotension and that widening pulse pressure. And then when it comes to the severe asthma exacerbation, parenteral beta agonists such as intramuscular epinephrine or terbutaline are rarely needed, but in these severe cases, they can be helpful. And so epinephrine given IM may be more beneficial than terbutaline in severe cases. There's limited evidence, but I'd say in situations, especially with there might be a concurrent anaphylaxis as a trigger, giving intramuscular epinephrine can be helpful in that situation. I found that when I've gotten to this point of needing to give something for a severe asthma exacerbation, this patient may have already been on continuous albuterol for so many hours, then the benefit of terbutaline at that point is limited. We know that from the evidence that terbutaline, if given early, can be beneficial, but at this point, if beta receptors are saturated from the use of continuous albuterol, then the benefit of then adding terbutaline at that point may be limited. And in situations where respiratory failure exists, non-invasive positive pressure can be a good strategy, such as BiPAP, before proceeding to something that could be even riskier with this disease process, like intubation, which with the barotrauma can lead to pneumothorax or just difficulty in ventilation. So in terms of non-standard treatment, there is insufficient evidence to support the routine use of things that I've noted here, like Heliox, ketamine, leukotriene receptor antagonists for acute asthma exacerbations. However, there may be unique situations where you may want to use them. So Heliox, it's something I would say I rarely use, but mixture of helium and oxygen, when co-administered with a beta agonist, to those that don't respond to conventional therapy may be helpful. The theory is that lower gas density of helium results in decreased flow resistance to allow more oxygenation at the alveolar level, but it shouldn't be used in patients that are requiring more than 40% oxygen. In terms of ketamine, ketamine has, as you may know, has bronchodilator properties. When I'm going to the point of placing a patient, escalating even beyond BiPAP and having to intubate the asthmatic patient, my typical go-to agent in terms of for use of rapid sequence intubation is to use ketamine for that reason. And in terms of leukotriene receptor antagonists, however, it's not supported in the existing literature for either urgent or emergent acute asthma exacerbations. Can be helpful for preventative treatment, however. So I think there are opportunities for improvement, however, in what we do. So I've described what the standard treatment for asthma is, but I do think there are some gaps in how we deal with asthma along the emergency care continuum, and also how we deal with asthma post-discharge and the risk of asthma that can occur with comorbid conditions such as influenza. So I'm going to touch on each of these over the next few minutes. So in terms of the emergency care continuum, I think you've heard from each of my colleagues, Dr. Arbach, Dr. Geshe-Hill, about the importance of that concept of the emergency care continuum. We know that care does not begin in the emergency department when it comes to emergency care. It occurs well before that in the out-of-hospital setting. And so this is true even for asthma. And so when it comes to that, I'm going to share with you what we have done in my own city, in the city of Houston, to help improve asthma care for children. So back in 2012, we reviewed the evidence to create an evidence-based guideline for asthma management in the pre-hospital setting for children. And so we implemented these guidelines that you see here of what to do and what not to do. And so you'll see on here many of the things that I already said: use of albuterol, use of ipratropium, use of steroids, use of magnesium, and use of intramuscular epinephrine in severe cases. So prior to this, our treatment mainstay in the EMS setting in our city was just to use albuterol and just to give intramuscular or intravenous methylprednisolone, and that's it. There was no use of ipratropium, there was nothing else. And so we implemented changes, and one of the main changes that we made was implementation of oral steroids on the ambulance. So before, we only used intramuscular and intravenous methylprednisolone. Well, as you may know, starting an IV on a child in the pre-hospital setting can be challenging for a paramedic who mostly takes care of adults. And then it also creates a barrier to administration of the medication. So to be able to provide them with an alternative route that is much easier to administer in terms of the oral route was helpful. And so I'm going to show you some of that data. So we implemented the use of oral dexamethasone on the ambulance back in 2014. Eventually, when we were able to implement the dexamethasone piece to the guideline. And this has actually been incorporated into national guidelines that we have for EMS through the National Model EMS Clinical Guidelines that we have in the United States. So we actually studied this. We studied this in about 482 patients before and after. And what we saw in this study that we did is that the median total hospital time after the protocol changed decreased. We also saw that more steroids were given after implementation of the guideline. And it increased from just modestly from 11 to 18%. But what we saw is that the paramedics started to exclusively use the oral route. And so really in talking to the paramedics, this was a big shift in being able to give them the opportunity to give oral steroids by another route. And so, but what did we see in terms of more long-term outcome that led into the hospitals? That their total hospital time after the protocol change decreased by about 1.6 hours. Total care time, defined as time from ambulance arrival to hospital discharge, also decreased by about 1.4 hours. Patients were also less likely to be admitted to the hospital. And with the more severe exacerbations, they were less likely to be admitted to a critical care unit. And so, although this was a single site study before and after trial, what we saw was some promising results that others are planning to study in the United States as well in terms of implementation of oral glucocorticoids on ambulances for the pediatric patient. I think another opportunity for improvement is how are we preventing emergency department recidivism? Many of the patients that we see in the emergency department have poorly controlled asthma. and yet sometimes we fail to ask them about the chronicity of their symptoms. And so there is good evidence that shows that discharging our pediatric patients who have chronic asthma symptoms on an inhaled corticosteroid does prevent bounce back visits or ED recidivism. And so it's important to screen those patients to find out how many asthma exacerbations have they had in the past year? Do they have frequent nighttime cough? And so one quality improvement measure that we have implemented in our own emergency department is really focusing on identification of the chronicity of a child's symptoms and then discharging them on with a prescription for an inhaled corticosteroid. Another thing that we've implemented as a quality improvement measure is integrating influenza vaccination orders in our asthma order set, because we know that children who have who have asthma and then get influenza have worse outcomes than those that do not have asthma. And so I think it's a great opportunity. Many of the patients that we see often don't have an influenza vaccine when they come in for their asthma exacerbation. And so being able to screen them for their vaccination status and then ask them, would you be willing to get the influenza vaccine during your emergency department visit? And so I frequently have given the flu vaccine to asthmatic patients in that situation. And so that can be helpful as well. And then I think the last thing in terms of opportunity for improvement is what sort of anticipatory guidance are we giving to our patients in terms of discharge planning? And so we are try to be very good about sending every patient home with an asthma action plan so that they know, okay, under normal conditions, what am I supposed to do? And so if we're sending somebody home on an inhaled corticosteroid, I'm supposed to take that medicine twice a day to prevent symptoms of chronic asthma. If I'm starting to have cough congestion and signs of attack of wheezing, shortness of breath, to use albuterol as needed. And then in situations where it may be more severe, to then escalate and then even seek care. So in summary, I think that there are several things that we can do to improve how we treat pediatric asthma exacerbations in the emergency department setting. Timely initiation of proven asthma therapy is essential. I think it's also important, though, as I mentioned, to consider the whole continuum of emergency care and how can you improve that care before the child even gets to your emergency department. And then finally, providing clear discharge and recommendations upon discharge, and then using those opportunities to discharge them with an inhaled corticosteroid if needed, and to ensure that they're vaccinated against influenza is also important. Thank you.